everyone. Hello, my name is Dr. Rafi Orfalian. I'm a resident at Kaiser Los Angeles. Today I'll be your moderator, and I have the honor of introducing Dr. Hansel J. Otero. He'll be speaking on the topic on postnatal imaging of prenatally diagnosed urinary tract infection. Dr. Hansel is the director of International Pediatric Radiology Education and Outreach, the Department of Radiology at the Children's Hospital of Philadelphia, where he joined as an attending pediatric radiologist and currently an assistant professor of radiology there. He is currently the vice president of Health for the World. And without further ado, I'll have him start his presentation. During the conference, we'll have anyone that wants to join and let us know where you're from and chime in and tell us, introduce yourselves in the chat box. And then during the conversation, during the presentation, you can ask questions in the Q&A box and we can cover it at the very end.
Excellent. Well, first of all, thank you so much for the invitation. I've been following some of these grand rounds at radiology, and all the topics have been great. So it's an honor to be here, to be honest. And thank you, Rafi, for the introduction. As he said, the topic today is going to be postnatal imaging of prenatally diagnosed urinary tract dilatation. And this is going to be more like a pictorial essay. I'm going to drive you and walk you through some of the cases and give you some of the background, and hopefully you along the way you'll catch some practical points and take home points of how to image for these kids and how to follow them up. So let's get started. Like, all right. So these are our objective. Describe the UTD risk-based classification. We're going to talk about, again, indications, advantages, and disadvantages of the imaging modalities that are involved. And then I'm going to also take a little bit of time to show you alternative imaging modalities, particularly for reflux and function. As a background, UTD, urinary tract dilatation, is very common. It's present in about 0.5 to 1% of all pregnancies. Some older numbers actually said that it's 1 to 3% of all pregnancies, and it's only second to cardiac defects. So again, very common prenatally. Is diagnosed with any type of dilatation of the urinary system, and it is a heterogeneous group. It includes transient dilatation, and those are some are gonna resolve before birth, but the great majority are gonna actually resolve without surgery in the postnatal period. Then we have reflux, we have obstruction at different points, we have UPJ obstruction, UVJ obstruction, and lower urinary tract obstruction. Again, I'm going to walk you through some of those diagnoses as we look at the imaging. Again, a little bit more background. In 2014, this multidisciplinary consensus was published. It was a result of work or again, consensus among experts from 8 different societies. It includes the ACR, the Society of Pediatric Radiology, but also the Institute of Ultrasound Medicine and the MFN community. It was also adopted or is now being adopted by the American Academy of Pediatrics. So the idea was to use a single classification for prenatal and postnatal urinary tract dilatation. It also provides a little bit of the terminology that we want to be using to avoid, there was a lot of confusion about mild, moderate, severe, or, what really constitutes hydronephrosis and pelvic fullness and some other words that might be confusing for the reader. Then This particular classification is going to be a risk categorization. So you are either low risk, intermediate risk, or high risk. And it provides us a little bit of a roadmap of how to use image in the postnatal period. And that's where we're going to spend our time today. To simplify it, in the prenatal period between 16 and 27 weeks, anything over 4 millimeters is considered dilatation, less than 4 millimeters is normal, and at 28 weeks, it changes to 7 millimeters. So, and the prenatal dilatation is only low risk or high risk. So we have A1 or A2-3. Postnatal, anything under 10 is normal. So you can have someone that was read at, an ultrasound at 28 weeks prenatally that says this patient has urinary tract dilatation. And then when they're born at the same 7 millimeters, it doesn't meet the criterion for postnatal urinary tract dilatation. So those kids are going to be, let's say, cured just by using our criteria, okay? This is a table we published in last year, and it's just to show you. Again, normal is less than 10 millimeters, and then we have urinary tract dilatation postnatal 1, 2, and 3, that it goes low risk, intermediate risk, high risk. Not just based on the renal pelvic diameter, but also the calyceal dilatation makes a P1. When you include not only the central calyces, but the peripheral calyces, it makes you P2. And you can have abnormal ureters. And then P3 is the high-risk group that is not only more dilated, but it also can have abnormalities of the bladder or urethra. And it has also abnormalities in the parenchyma. This is a nice illustration from paper published in 2017 by Dr. Chow from Boston. And just to show you again, like this is normal. P1, you have central calyceal dilatation. For P2, you have some of those peripheral calyces showing up. And for P3, you have changes in the parenchyma. Let me walk you through it one more time. Normal. And remember that in newborns, we have great resolution with ultrasound. So the kidneys are kind of right there. We can image them really well, and we see not only the cortex, but the pyramids and the renal pelvis really well. So this would be normal. For UTD-P1, we have dilatation of the central calyces. It's low risk. For UTD-P2, you have more dilatation, including the peripheral calyces start to show up. And you might have dilatation of the ureters or as well. So this is kind of the illustration there. For P3, you can have different appearances as well. If you have diffuse parenchymal thinning, it's already P3. And if you have abnormal bladder, or in this case, a uterocele, then it also makes a high risk, again, a P3. The other thing that can make it P3, even if it's not as ugly and dilated as this kidney, is if you have, again, parenchymal abnormalities such as cyst. Here at CHOP, at the Children's Hospital of Philadelphia, we translated those guidelines into this clinical pathway. The clinical pathway is available to the public. So here I leave you with a website if you are curious. But basically, again, you have low risk, intermediate risk, and high risk based on the first ultrasound after birth. And the idea is that each group, it tells you if you need to consult urology, yes or no. Do you need a repeat ultrasound? It can be at 6 weeks, 12 weeks for high risk, but it can also be at 6 months or a year for low risk. Do you need prophylactic antibiotics or not? And this is a big driver for our colleagues in the NICU and the nurseries. They don't want to be using antibiotics in patients that don't need it. Then we need to check for reflux with PCUG or do functional imaging that can be done with MAT3 or MRU. So again, our first stop is ultrasound. It has many advantages. It's non-invasive, it's available, radiation-free, it's portable. We can use it in the sickest of our patients because we can go to the NICU and do it there. It is less costly than other alternative modalities. And it has also the benefit of not needing a specific positioning. So we can scan babies, prone, supine, while the parents are holding them. We try to be very flexible about how to image. Whatever makes the baby comfortable and the parents comfortable, then we can image or almost all the time. Again, ultrasound is always the first modality, and I'm going to tell you, and this is probably the first practical tip, and you want to always try to wait 48 hours. I put always, and then I say it's not true, because there are certain exceptions. When you have patients at high risk, especially those patients that come with a diagnosis of lower urinary tract obstruction, like posterior urethral valve, then you might want to scan those kids early on, even within the first 48 hours. The other thing is that there was some work done that if you image the patients prone, up to 10% of the patients might be upstage, might change from UTDP1 to UTDP2, and because there are implications for management, you might consider imaging prone all of your babies with antenatal diagnosis of UTD. We also image the bladder first, because remember, babies that have no bladder control, so you want to have a sense of how the bladder looks pre and post void. So we start with the bladder. If the bladder is full, nice, because then you have already the pre-void, and then you check at the end of the exam, and hopefully you get the post-void images. But if you start with an empty bladder, by the end of the exam, you have some urine there, and then you still have something to compare to. So we start with the bladder, then go back to the kidneys, come back to the bladder, the study's done. And every kid with antenatal diagnosis of urinary tract dilatation will need at least 2 ultrasounds. Okay, so it will need 1 ultrasound at birth, and if that one is normal, some urologists and nephrologists will recommend that a year later you check again, and some others use 6 months to be a little bit closer follow-up. But once you are born with UTD, you need 2 ultrasounds. These are prenatal images, and I want to show you, this is one of the first examples I bring you. So this is how we are supposed to do the prenatal imaging, with a spine at the 12 o'clock position. You see both kidneys, right and left. You see that the right kidney has some dilatation, not only of the pelvis, but of the calyces. We see it here really nicely. And then on the left, we have a little bit more dilatation with the renal pelvis being bigger, and again we see the dilatation of those calyces. All right, so this baby was imaged like this at 37 weeks. Baby is born, and day 0 we decide to image. Day 0, the right kidney is completely normal. You see 0, no dilatation. The left kidney has P1, just a little bit of central calyceal dilatation. That's it. So if you do your risk analysis at day 0, you are, again, giving them a normal right and a low risk left. The issue is that babies, we know, from our clinical rotations, from having babies ourselves, or just from imaging them, that the babies or newborns have a problem with fluids, right? Like they have a lot of edema when they're born. They have extra vascular fluid, but they're vascularly depleted. So, and they haven't started to produce enough urine to give us the same picture that we had prenatally. So this same baby comes back 2 days later. And you see that the right kidney has central calyceal dilatation, and the left kidney looks a lot worse. It's not only central, but it goes into the peripheral calyces. And now we see that it's not only the pelvis, but the ureter looks dilated. So now we're going to upstage this patient to P1 on the right and P2 on the left. What does that mean? That means that we either wasted our time with the first ultrasound, and that's what we want to teach everybody, or we could base all of our follow-up workup with the wrong assumption. So again, just to compare the P1 and the P2, what I want you to see is that when we were saying normal right P1 on the left, there was no indication for BCUG. With intermediate risk, BCUG might be indicated. Again, BCUG is a little bit more complicated because we also have a lot of other, we reserve it for P2 or P3, but it's not only based on UTD. It's also based on clinical findings, including if it's a male or female baby, knowing that female have more reflux. We also might consider if the patient is circumcised or not, and a lot of other things that the urologist and the neonatologist will know. But from the imaging point of view, with P1, we said no BCUG at all. With P2, we might need it. This baby went to BCUG, and these are the images. So you see that there is reflux into both sides. All right. Even here after void, we still have some residual contrast in both collecting systems. And the ureters are very dilated. So just a quick pit stop to check on BCUG. UTD by itself is not an indication, particularly if the ureter is normal. And BCUG is not indicated when you have unilateral UPJ obstruction or multicystic dysplastic kidney. If your contralateral kidney is normal, you don't need a BCUG for those indications. Again, other clinical parameters apply, but I want you to at least know these basics. And in terms of imaging, just remember that for BCUG, we're going to do an early filling because that can show us a ureterocele better. We are going to do obliques with full bladder because we want to see if there is grade 2, grade 1 reflux, or if we're going to see, again, diverticula from the bladder. We take pictures of the urethra with and without the catheter, and we take pictures of the renal fossa. If we see reflux, it's important. This is very important for management. If you see reflux, you need to repeat or provide a delay imaging that includes the kidneys and the bladder. And after a delay, because what you want to see is if what the contrast that is refluxing easily comes back to the bladder and is excreted again. All right, and more important than the degree of dilatation and reflux, one thing that is more important to differentiate between those that are going to need surgery and those that are not going to need surgery is the timing of the reflux. So if you have early reflux with early filling, those kids will probably need surgery. If you have reflux only during voiding and it comes back nicely in the delay, those are less likely to have surgery. This is to show you a different modality that you can do evaluate for reflux as well. So these images on the left, and this is going to be a contrast enhanced vesical sonography. And for this one, what we're doing is we're using ultrasound contrast to fill the bladder. I remember that the ultrasound contrasts are microbubbles. We are adopting this technology kind of from our cardiology colleagues that have been using it for echo for a lot, many more years. And what we're doing is just injecting the contrast through the bladder catheter. We see all those bubbles getting into the bladder. And then we image intermittently both renal fossa. And we see that contrast getting, again, here in grayscale, here is the contrast getting into that, in this case, into the lower pole. I'm gonna show it to you now to compare it with regular VCUG. This is same baby. This is a VCUG, and this is our contrast enhanced voiding sonography, where you see that same reflux, in this case, into a lower pole moiety. This is another example, again, VCUG, and this would be the ultrasound image of that reflux on that left kidney. I don't want you to think that this is a technique that is exclusive for the left kidney. So let's review reflux on the right kidney now. So what I did here is I flipped over the ultrasound image just to look at the reflux into the right kidney that looks very similar in ultrasound. And when we see pictures of the bladder, again, this is a bladder full with contrast, and we do see the reflux into that dilated ureter. So again, the findings are similar findings than the VCUG. As per usual, ultrasound has a limited field of view, so you need to know what you're looking for, and you need to change your field of view intermittently from bladder to ureters to kidneys. It is you can also see the urethra with a perineal approach. So in this case, again, the image is upside down because the probe is in the perineal area. So you can see the entire urethra. Advantages of using ultrasound. I think ultrasound is more available. So I think that there might be a benefit that is easier to adopt in smaller hospitals or in hospitals that don't have fluoroscopy. Also because ultrasound equipment is easier and cheaper to get and to maintain. It is a friendlier environment. Like if you know how the fluoroscopy rooms work, like the machine is big and make noises, and the camera is really big and hovers over the baby. So this is a much friendlier environment, just your regular ultrasound room with no special preparation. Again, in small babies, the parents can hold the baby, and that is an advantage. In older patients, particularly after they're potty trained, it's important that they can void, they can pee sitting down. And that is important because we can image while they void in the sitting down position. That is a lot more comfortable than, you spend all this time as a parent teaching them not to pee their beds and not to pee in bed. And then they come for this test and you're telling them to actively, please pee on the bed. So it's really hard. So for that, it's easier to do it under ultrasound where they can be sitting down. And the other thing that we see is that because these are bubbles and the position is changing, we see at least a few bubbles going up all the way to the collecting system. So we don't see a lot of grade 1 reflux. Instead of the reflux staying in the ureter, we always see it at least a little bit coming all the way up. So there might be an increased sensitivity for this test compared to VCUG. All right, so this is our original patient. Again, we did the imaging correctly at day 2, so we diagnosed him with P1 on the right, P2 on the left. We diagnosed him with reflux. So now the question is, what is the function on that baby? For functional analysis, you want to wait at least 6 weeks. And I'm going to show you now functional. So this is a follow-up. Again, 2 months. The baby is now 2 months. 6 weeks have passed by. The findings are still there. So they go from the follow-up ultrasound to function. And function can be evaluated with a number of radio tracers. The MSA is actually not the most common one. The MSA we use for scarring. And remember that in nuclear medicine, this is going to be the right kidney, and this is going to be the left kidney, because it's a posterior view. And in this case, we do see that the uptake on that left kidney is down, and both the function that it provides is asymmetric, provided by the right kidney. So there is already damage to that left kidney, and we wouldn't have gotten there if we did the wrong staging at the very beginning. This is a different baby, but I want to show you kind of similar findings. It's an ultrasound when they're born at 48 hours. So in this case, it was March of 2019. In April, they get their follow-up ultrasound, and in May, they get their nuclear medicine study. These are the ultrasound findings with normal left kidney, the right kidney is dilated. We go to nukes. Nukes, we calculate the function with the first 2 minutes after the injection. And then we see the drainage after 20 minutes. If there is, some institutions use 15 minutes, some institutions use 20 minutes. But if there is persistent activity, then we give Lasix. And we generate this curve where we see that the right kidney in this case, that again, that was the abnormal kidney, is accumulating radiotracer and only responds after Lasix. It gives us the differential function, telling us that the left kidney is doing most of the work, the right kidney is collaborating with 36%. This is a very important concept, so I'm going to start yet another patient, similar findings. Again, you do your ultrasound. It goes from ultrasound to functional imaging, and this is how we code for our BCUGs, or reflux. So anyway, the right kidney is normal, the left kidney has dilatation. You would call it like P2 if you don't see anything on the parenchyma. And this is a MAC3. And again, we have that dilatation of that left kidney that requires Lasix to, and even after Lasix, you still don't have complete clearance. The function is 40 and 60, so it's still preserved. You still have preserved function, but again, that left kidney is, as we saw here, is dilated and is taking too long to drain. How UPJ obstruction looks? Well, you start going up and it never goes down. The activity never goes down because it never drains. And this is the concept that I want to show you. What we're trying to do is we're going to use these radio tracers and that are going to accumulate in the kidney and the collecting system. And this is our level of narrowing, right? When we if Lasix, if it's really stenotic, the activity will exacerbate that accumulation in the renal pelvis. If it's dilated but not stenotic, it will drain a lot faster. So this graph explains why we give Lasix. We want to force and try to differentiate between the ones that are dilated but unobstructed from those that are dilated and obstructed. And again, the curve is completely different because one will show you this that never drains, and the other one, like I showed you in the previous patient, will go up, but the drain after Lasix. This is the same patient after pyeloplasty, and I want you to see that there is no complete resolution of the calyceal dilatation. Why? Because it's a little bit like a balloon. Once you inflate a balloon, it doesn't. When you deflate it, it doesn't go back to completely normal. It goes to this kind of capacious shape. All right. So again, remember this analogy because recognizing that these patients are not obstructed is the goal. You're going to recognize that this is something patulous and dilated, but it's not obstructed. Hence, doesn't need any further intervention. The alternative to nuclear medicine is MR urography. This is how normal looks like. We're going to give contrast, but we're going to give the Lasix before the patient gets into the magnet. So the contrast goes straight through the kidneys and into the collecting system and the bladder. And if it's normal, it looks like this. And because this is a dynamic imaging, we can do the segmentation and provide curves that are very similar to what we see in nuclear medicine. But for the fact that instead of waiting 40 minutes of images, we only have 8 minutes, because again, we gave the Lasix at the very beginning and all we want to see is a little bit of drainage. How UPJ obstruction looks? Well, these are T2 images, T2 weighted images that show the dilatation. The T2 axial images show not only the dilatation of the calyces, but of the renal pelvis. This is our 3D model. And when we do our curve, this is how it's going to look. One of the kidneys is going to have contrast going through and never draining, while the normal kidney, in this case the left, it takes all that contrast but then rapidly excreted. That to differentiate from this one. And what I want to show you on this one is that we have a dilated system on the left, but we see in the dynamic images that the parenchyma is of good quality, like it's draining rapidly, and it's opacifying our ureter. So this is a dilated system that is not obstructed. You see the dilated system, but you see the contrast getting through. So when we see our numbers from our curve, you see that the renal, we are going to calculate the calyceal transit time and renal transit time, and it's not on the obstructed category. So again, dilated system versus obstructed system. That's the main differentiation. Okay, so now we review how to do ultrasound, the indication, the timing, and the proper technique. We review VCUG. We review the opportunity of doing contrast enhanced ultrasound to substitute VCUG. And then we talk about nuclear medicine and why we do renal functional imaging, and how we can replace functional imaging with nuclear medicine by doing MR urography, functional MR urography. So this is my summary. We discussed the UTD classification, the imaging techniques. Please remember, UTD evaluation always start with ultrasound. The majority of the cases is after 48 hours, and the risk dictates the need for additional imaging. For us, it's important because it stops us from getting multiple ultrasounds that are not needed, and also reduces the number of VCUGs that are ordered, and the number of functional images that are imaging studies that are ordered. But for the patient, the parents, and the rest of the medical community, it's also important that they are not unnecessary urology consults in patients with low risk. And most important for the patient is that they don't. A lot of patients don't require prophylactic antibiotics. Remember that prophylactic antibiotics have a number of side effects and risks associated with it, and and the compliance is not that high anyway. Reflux can be evaluated with VCUG or contrast enhanced ultrasound, and then function you can evaluate with nuclear medicine or functional MRU. And the main thing that I want you to remember about functional imaging, beyond the number, beyond the split function, 40% versus 60% or 20% versus 80%, is it can help us differentiate what is dilated, what is obstructed. And with that, I thank you for the invitation and for hanging out with me this morning. And I leave you with my email.
Thank you so much for that lecture, Dr. Otero. That is very informational. Very interesting. They contrast and test VCUG or VCUS. That's something I wanted to look into. Um, I'm going to take this little opportunity to say greetings from everyone pretty much around the world. So there is a good number of participants today. Dr. Dechen from Bhutan and Dr. Idun from Ghana says hello. Greetings from Mexico from Dr. Mainero. Um, we also have Eukaria Mushosho from Zimbabwe. Kalaluka Mundanda from Zambia, Dr. Mundana from Zambia. We have Dr. Madila from Después Letichad. These are difficult to say too. Dr. Giovanni Udupihili from Sri Lanka. Also some other couple people from Colombia as well. So we have quite a lot of participants today. And moving forward with the question and answer portion of the lecture today. So one of the questions is, could you tell me the exact timing of the LASIX before the MRU? Do you do the dynamic MRU / the twist sequence? And this is from Yanni.
So for MRU, different than nukes, what we do is we hydrate the patient before getting them to the scanner, and we give them IV saline. We put a Foley catheter, and we give them the LASIX at the time that they are getting to the table. So the timing, to use similar terminology as nuclear medicine, would be T0. Your furosemide or LASIX is given before starting any imaging. So again, the nuclear medicine terminology would be T0. You are right that the series are borrowed from the angiography, from time resolve. So you can use twist, but we actually use Vive. Remember that you are going to image for 8 minutes, or at least 8 minutes. So we use a Dixon technique, water fat separation. And it's a gradient, so it's really fast. So each of the phases is about 10 seconds. And we do at the beginning 10 seconds back to back, and then we space it a little bit more. And then towards the end, it's just 10 seconds every 30 seconds of imaging. But what you want is to extend the number of phases, so you end up with 8 minutes of imaging or 10 minutes of imaging.
And then another question, until what age can a child have the UTT classification be applied to?
That's a very good question, because it's kind of tricky. We're even still working it out here. In general terms, in terms of using the descriptors, central calyceal dilatation, peripheral calyceal dilatation, and measuring the, I remember that this classification kind of merges the Society of Fetal Urology classification with the AP renal pelvic diameter. So it uses a number of parameters. And the good thing is that we don't need to say mild calyceal dilatation or mild central. Is central or is peripheral? So it's there or it's not. It improves the inter-reader agreement. You can use it at any time if you know that your urologists are understanding it. The idea of the classification itself is to give you a good start. So we use it in newborns, we use it in infants, and we certainly have patients that even present late, but we think it's a congenital obstructive uropathy. So we keep using it even in a 5-year-old or in a 7-year-old. So I want to say that it's not an age criteria, it's more what you think the pathology underneath is. You cannot use UTD classification if you're talking about other types of obstruction. Stones, for example. Stones are super common. And if you use UTD, you're going to fail at detecting obstructing stones left and right. So don't use it for things that are not congenital obstructive uropathy. So that would be the recommendation.
Excellent. And then at what gestational age can ultrasound detect UTD?
So there are, I show you, I don't do prenatal, but but the UTD classifications starts with how in the States, a normal pregnancy will only undergo 2 ultrasounds. One is early on, is during the second trimester, and it's people call it like an anatomical survey. So at that point is when they first appear, and that one is usually around the 14 weeks. Now, again, it doesn't necessarily reflect when is the first time that you can see it. Is about the first time that they actually get scanned. And then the second ultrasound is kind of when in the third trimester. And that one is when we switch from 4 millimeters to 7 millimeters.
Here's a question from Varsha. Is how to differentiate the, I want to say VUJ, obstruction versus extrarenal pelvis, if the renal pelvis AP diameter is 11 millimeters, and where do we fit that into the UTD?
Well, that's part of the beauty of it. I don't want you to try to differentiate. People have tried a number of different things with ultrasound: hydronephrotic index, color Doppler, using the resistive indices. The truth is, what has more evidence and is easier to manage is look at the size of the renal pelvis. If it's a normal variant extrarenal pelvis, is easy to differentiate. But if you have more than 10, you give a follow-up. That's all you need. So if you have a renal pelvis that is 11 millimeters and you're trying to differentiate if this is just mild dilatation or UPJ obstruction, give it a follow-up. Consider the other parameters and give a follow-up. At 11 and constant, nobody's going to do anything, and it's going to eventually resolve. At 11 and getting worse, people will eventually move to other reflux imaging, functional imaging, and other diagnoses.
Excellent. Here's a question from Giovanni. How do you correctly differentiate VUJ obstruction from a megaureter?
So we're getting into the same question of how do you differentiate a capacious system that is taking a long time to drain because it's capacious versus a system that is actually obstructed. And again, there are a number of imaging parameters when you see the narrowing and you see the atretic segment. But for those cases, actually what you want to do is just get delay imaging, maybe image the patient on prone and just try to, and the other big thing is time. Again, if you do functional imaging and the function of that kidney is deteriorating, that's a red flag for our urologist to go and intervene.
Here's a question. What are the advantages of renal scintigraphy, FMEU, versus the renal function test, like lab tests?
Well, the issue with the lab test is that they are for both kidneys. So remember that a lot of these patients will have a completely normal kidney and one that you're trying to save, or one that is at risk. So if you use only lab tests to monitor, you are basically putting that, like, assuming that you don't care about that kidney at risk. Because with one kidney, we're going to still function, have normal function, till adulthood.
Great. And then What are the measurements we need to provide the surgeon before and after pyeloplasty for Pujo, Pujo?
So if sorry, this is UPJ obstruction, and the parameters that we give them is how fast the contrast leave the parenchyma and goes into the calyces, and how fast the contrast leave the collecting system to be on the proximal ureter. So again, that is going to be calyceal transit time and renal transit time. Renal transit time below 4 is normal. 4 to 8, it depends on the size, but it can be a capacious system that is not obstructed, and more than 8 is obstructed. So that's what that's to highlight one more time. What we want to separate is the capacious system from the obstructed system. And if in a follow-up after surgery, we see that there is less dilatation, even if not completely normal, and we see that the functional parameters improve, again, no back to normal, just improve, then we know it's not obstructed or it's not critical obstructed, so it doesn't need reintervention.
Excellent. We have one more question. See, which is the role of the gammogram in the study of the kidney?
I'm not too sure what a gammogram is, to be honest. Like, I know that nuclear medicine has several names, and this sounds like it would be one of those names, but I'm not familiar with that name. so,
So,
so again, we do use nuclear medicine in a number of scenarios, including more importantly for function, but also when we're looking for scarring. And function is important because some surgeons have the again, there is a lot of variability on surgical practices, but some urologists will try to rescue, a kidney that it's slow when it's only providing 20% of function. But if they're only providing 1% of function, they're more likely to just, and it's giving them trouble with infection and whatnot, if they're more likely to just remove the kidney. So you're trying to differentiate what is worth salvaging.
Gotcha. And we'll have one more question. Let's see. The question is from Sanja, and they're asking, how can you differentiate VUR from PUV postnatally using contrast enhanced ultrasound?
So the findings are going to be exactly the same as VCUG. And here the question is, can you differentiate reflux in the presence of posterior urethral valve or reflux without posterior urethral valve? Again, part of your examination, the ultrasound, is go through that transperineal image that gives you the voiding urethral image. So it's going to give you, very similar to VCUG, a very dilated posterior urethra with a narrow inside and then just minimal voiding. And you are going to know that that's a posterior urethral valve. For other patients, you will see a completely normal urethra, and the reflux can be present or not, but the image of the urethra is very important. However, last little thing would be that some of our urologists and providers will still prefer to do VCUG because it's easier for them to see and they have more experience with it, and save the contrast enhanced ultrasound voiding study for girls, for patients that already have a baseline, so they already know the anatomy of the urethra they want to know, and all they want to know is the follow-up of the actual reflux. So again, you can use it to substitute some of the other indications if you are unsure about imaging the urethra.
Excellent. Thank you so much, Dr. Otero. I am all the other 84 participants internationally say thank you, and we're very appreciative of your time, and thank you for the excellent lecture.
No, again, thank you for the invitation and for having me. It's nice to see people from all around.
Excellent. So that will conclude our grand rounds for today. Appreciate everyone for joining in, and we'll see you soon. Thank you.
Thank you, guys.